Portal hypertension is defined when the corrected free portal pressure, which is the pressure in the free portal vein minus the pressure in the inferior vena cava, exceeds the 5 millimeters of mercury. If we do super selective catheterization of the hepatic veins and obtain a pressure with the catheter in the vegetative position, usually that reflects the pressure in the portal vein. When we move to the free hepatic vein position, that reflects the pressure in the inferior vena cava. So a simple modality of doing manometry is to do hepatic vein catheterization. Now, in the classification of portal hypertension, like with pulmonary hypertension, we have a situation where there is increased resistance to the flow of blood through the liver and conditions that increase the blood flow through the liver. Or we may have a combination of both. The most common mechanism of portal hypertension is due to increased resistance of transhepatic portal blood flow. The obstruction can be beyond the liver, and it can be within the liver in the region of the hepatic venules, in the hepatic veins, or in the inferior vena cava. And this is called post-hepatic portal hypertension. So any condition that produces high pressures in the inferior vena cava, such as obstruction, congenital bands or webs, etc., or cardiac conditions such as constricted pericarditis can lead to portal hypertension. Congestive heart failure will follow also into that category. The obstruction of the hepatic veins can occur congenitally or can be an acquired process. And usually the acquired conditions are the most common one, and they are usually called the Budd-Chiari syndrome. Later we will discuss it in greater detail. And Budd-Chiari can be the result of increase in intravascular coagulation, like some types of blood dyscrasias. It can be inflammatory, can be neoplastic, or secondary to trauma. Now, the most common cause of portal hypertension is the intrahepatic, and here we have the sinusoidal, post-sinusoidal, represented by cirrhosis of the liver, and the pre-sinusoidal causes of portal hypertension, which includes a number of entities such as schistosomiasis, hepatoportal fibrosis, portal infiltrates, the entity called partial nodular transformation of the liver, and even some AV malformations. Finally, the prehepatic causes of portal hypertension are usually secondary to the inflammation in topography of the pancreas. We can see congenital causes of portal vein thrombosis, such as ampulitis, or secondary to umbilical vein transfusions, trauma, AV fistulas, and malignancies that involve primarily the pancreas, stomach, bowel, or lymph nodes. In the physiopathology of portal hypertension due to liver cirrhosis, we mentioned that the increased resistance to the transhepatic portal flow due primarily to sinusoidal, post-sinusoidal obstruction is the major mechanism. However, when the spleen enlarges considerably, there is increased portal flow coming primarily from the spleen. So it is to be considered like a gigantic arteriovenous fistula. In other words, there is excessive blood flow going through the spleen, and the egress of blood from the spleen into the portal system contributes to an increased flow. And this is what we call the mixed form of portal hypertension. Finally, we have situations, as we shall describe later, where there is no increase in the resistance of blood flow through the liver, except that there is a primary increase portal blood flow. And this is usually the result of an arteriovenous fistula between the hepatic artery and the portal vein, or the splenic artery and the splenic vein. Eventually, the vascular capacity of the liver is exceeded, and elevation in the pressure of the portal system will result. Again, this is analogous to the mechanism of pulmonary hypertension, where there can be increased resistance, increased flow, or a combination of both. Now, in liver cirrhosis, the results of liver lobular distortion is part of the cirrhotic process. In other words, there is a triad of liver cell destruction, the regeneration of the liver cells, fibrosis, and distortion of the lobular architecture. This occurs in any type of cirrhosis of the liver. Because there is hepatic venous outflow obstruction, this leads to sinusoidal hypertension and a decrease in the total hepatic blood flow. Sinusoidal hypertension eventually results in a decreased portal flow to the liver, and there is going to eventually be a phenomenon called hepatofugal circulation, which means that blood that normally goes from organs to the portal system will go from the portal system to organs. And this is the mechanism of the development of varices, particularly gastroesophageal varices. There is also going to be an increase in the formation of lymph, and lymph is going to exude from the surface of the liver, and this is the hepatic origin of ascites, or it is going to exude at the level of the wall of the bowel. And in the latter case, ascites will have a low protein content, in contrast to the lymph that is of liver origin that has a high protein content. We are also going to see membrane changes that will tend to reduce hepatic flow within the liver. There will be an increase in the systemic lymph flow going into the thoracic duct, and as a result of increased lymph pressure, ascites will occur. Sinusoidal hypertension leads to portal hypertension and to the opening of collaterals and of tributaries to the portal system. This is the basic mechanism for development of varices that subsequent can bleed. There is also going to be, as we mentioned before, hepatofugal portal flow. Portal venous obstruction will increase hepatic arterial flow. So as a compensatory mechanism, like it occurs in the lung, when there is a decrease in pulmonary blood flow, there is a relative increase in bronchial flow in the presence of pulmonary ischemia. The result of portal venous obliteration will reduce hepatic blood flow in general, and because of liver cell destruction, we're going to see eventually liver cell regeneration, and that will also contribute to the distortion of the liver lobular architecture. The continued effect of whatever damages the liver is going to perpetuate the phenomena of liver cell destruction, regeneration, lobular distortion, and that explains the chronicity of cirrhotic changes in the liver. We are going to see also inflammatory changes and fibroblastic hyperplasia, which is commonly seen in any type of cirrhosis. And in summary, hemodynamics in portal hypertension due to cirrhosis of the liver will show increased intrahepatic pressures, increased portal venous pressure, increased hepatic arterial flow, a decrease portal perfusion of the liver, and actually the total liver blood flow may be significantly reduced, and that will contribute to the necrosis of the liver cells. Decreased total hepatic blood flow will contribute to liver cell necrosis. And finally, we're going to see increased partial systemic collateral blood flow with resultant formation of varices. The next four images correspond to four examples of cirrhosis of the liver. Cirrhosis of the liver used to be classified based on the mechanism, in view of the fact that, as with the lung, different injurious agents can produce the final similar results. In other words, the outcome of damage to the liver will be translated into destruction of liver cells, alteration of liver lobular architecture from the destruction of cells, and regeneration of liver parenchyma and fibrosis. The first group was the so-called nutritional alcoholic or LENEC type of cirrhosis. Now the new classification of this group of entities is called micronodular cirrhosis. In this first specimen, you can see that the liver is somewhat yellowish, and that is because of the fatty metamorphosis. And fatty metamorphosis is the first insult to the liver, and if it is persistent, it eventually leads to the other inflammatory changes and to the diffuse liver damage. This second specimen shows that nodules are much larger. In this particular case, they were relatively uniformly distributed throughout the liver. What do they represent? They represent the attempts of the liver to compensate for the damage, that is the regeneration of liver nodules, and the outline of these nodules is usually areas of fibrosis and of destroyed liver parenchyma. Note also the yellowish appearance of the liver due to the fatty metamorphosis. These patients have what has been now classified as a macronodular cirrhosis, and the old classification was of post-hepatic or post-necrotic form of cirrhosis. The necrosis can be the result of infection or of chemicals. This third specimen corresponds to a case of macronodular cirrhosis. Note the irregular distribution and the asymmetric involvement of the liver. The left lobe was less affected than the right lobe of the liver. This last specimen corresponds to a patient with macronodular cirrhosis. Note the globular enlargement of the right lobe and the marked atrophic left lobe of the liver. The so-called hobnail liver or macronodular cirrhosis can be confused with other conditions that produce nodules in the surface, such as syphilis and metastatic disease. This histological section of the cirrhotic liver shows the three basic histological lesions, which is the destruction of liver cells and regeneration of liver cells. Number two, the presence of fibrosis. And number three, the distortion of the liver lobular architecture. And these changes are responsible for the sinusoidal and post-sinusoidal obstruction and eventually portal hypertension. In these two diagrams, we want to contrast a normal situation with a patient with cirrhosis. In the top diagram, note that the inferior vena cava pressure is 5 millimeters of mercury. The wedge hepatic vein pressure is about 7 millimeters of mercury. So the corrected sinusoidal pressure, which is the difference between the two, is only 2 millimeters of mercury. This is normal. Also note that if we look at the pressure within the spleen, about 9 millimeters of mercury, the pressure in the portal vein, about 8 millimeters of mercury, only about 2 or 3 millimeters of gradient is the pressures between the portal vein and the hepatic vein. So any minimal increases in the resistance of blood flow through the liver will lead to elevation of pressures in the portal vein. So if we have a corrected sinusoidal pressure, which is the difference between the wedged and free hepatic vein positions, and this reflects the pressure in the portal system, the wedged pressure, and if it exceeds 5 millimeters of mercury, by definition, the patient has portal hypertension, and this is due to liver cirrhosis. In the diagram below, we depict the presence of nodules that can obliterate and compress the hepatic veins. We also have shown a wedge pressure that is arbitrarily selected, like 20 millimeters of mercury, with the pressure in the inferior vena cava or hepatic vein of 5. The corrected sinusoidal pressure now is 15, which is 3 times the normal corrected sinusoidal pressure. And once again, the pressure in the wedged position reflects the pressure in the portal vein. Why? Because there is intravenous anastomosis between the portal venules and the hepatic veins, as we shall show you later on cast corrosion preparations. This is a cast of right hepatic veins in a patient with cirrhosis. First, note the stunted branches. This is because they were obliterated by the fibrotic process and the regeneration of liver nodules with distortion of the liver lobules. Note that the major branches of the portal vein appear flattened. That is extrinsic pressure from the regenerated nodules. And this explains the post-sinusoidal mechanism of portal hypertension in liver cirrhosis. These 3 histological sections that we're going to describe represent the normal liver, the regenerated nodules, and hepatomas. In these three specimens, the stain was a Van Gieson technique. The first histological section shows the orderly arrangement of the liver cell plates, normal Kupffer cells, and normal vessels. This means that the reticuloendothelial system of the liver is intact. In this second case, we see the stain of the reticuloendothelial system, particularly the Kupffer cells, which surround the liver cell cords that are quite abundant. And this patient had normal vessels. There was a distortion of liver cell cords, but excessive number of liver Kupffer cells in proportion perhaps of slight increase in the vascularity. In this patient, we see evidence of malignancy. The patient had a hepatoma. The increase in the size and pigmentation of the nuclei and the distorted lobular structures are the result of the cancer. Note that we see absence of Kupffer cells, and we see a large number of vascular channels. The vascularity of tumors varies. In general, it is increased in hepatomas. What does this mean? This means that when we are doing phagocytic liver scans, or we are using a type of paramagnetic contrast agent on MRI, such as iron-based products, in the presence of hepatoma, there will be no uptake of these phagocytic agents. In the absence of Kupffer cells, even though there may be increased vascularity, there will be no uptake of the phagocytic product. On the other hand, in patients who have regenerated liver nodules, when there is a slight increase in the vascularity and increase in the reticuloendothelial system, there will be increased uptake. We're going to discuss the changes in liver vasculature in patients who have portal hypertension due to liver cirrhosis. This gross specimen corresponds to an alcoholic who developed micronodular cirrhosis. The liver weighed 1,400 grams. Red plastic was injected in the hepatic arteries, blue in the portal vein, and yellow in the portal veins. And note that the blue is missing in many areas of the liver. And for the first time, we see abundance of red. Remember the normal liver that I showed you at the beginning, where the blue and yellow dominated the picture. But the red is indicative that there is increased arterial blood supply to the liver. And some of the red vessels represent some collateral vessels that connected to the hepatic arteries. Note also the virtually absence of the yellow, and this is because of the two venous trees. The hepatic veins are more affected, and that is why it is described as sinusoidal, post-sinusoidal obstruction, the increased resistance of the transhepatic portal blood flow. The same liver seen from below and behind shows the hepatic segment of the inferior vena cava in yellow connected to the liver via the hepatic veins. Once again, we see a decrease in blue, increase in red, and marked decrease in the yellow. When cast corrosion preparations of the liver are made, one can hold the liver by grabbing the inferior vena cava. When I tried to do this in this patient, the liver dropped to the floor, and I ended up having in my hands only the inferior vena cava and the hepatic veins. This is because the anatomic connections of the cava to the liver are quite fragile and markedly diminished. Again, a reflection of the post-sinusoidal obstruction and the obliteration of numerous hepatic venules. Note that the hepatic veins are absent in many areas of the liver, and note that they're quite small in caliber, and there are many stunted branches of the hepatic veins. This patient had portal hypertension due to cirrhosis. A portal cable shunt was obtained, and we selectively catheterized a branch of the portal vein. Note that the catheter is in a peripheral branch of the portal vein, and contrast injected into this vessel shows quite rapidly the opacification of hepatic veins. The arrows indicate the intravenous anastomosis between the hepatic veins and the portal vein. And these are three sequences of the selective portal vein injection. So this explains why many of these patients develop septicemia. So the detoxification of products from the small and large bowel is not made, and some bacteria from the bowel find its way into the systemic circulation from these intravenous anastomosis between the portal vein and the hepatic venules. This is a cast corrosion showing the intravenous anastomosis. Note that blue was injected in the portal vein, yellow in the hepatic vein, and suddenly we see green vessels. This means that the blue of the portal vein mixed with the yellow of the hepatic vein to form green vessels. This is a morphologic demonstration of intravenous anastomosis. So we cannot establish exactly the level, but we can document the mixing of blood content, and in this case of plastic, between the portal vein and the hepatic veins. This is a selective common hepatic arteriogram in a patient with liver cirrhosis. Note that there is some retained contrast in the large bowel from a previous barium study. Note that the common hepatic artery is enlarged as well as primary branches, and within the liver we note the increase in size of hepatic arteries, tortuosity, and focal increases in blood flow. These are the arteriographic manifestations of liver cirrhosis. A cast corrosion of the hepatic arterial tree in a cirrhotic liver shows the enlargement of the large branches of the hepatic artery, the increase in the caliber of intrahepatic arteries, and the marked tortuosity seen in isolated branches of the hepatic artery that surround the specimen. When we cast simultaneously the portal system in blue, hepatic arteries in red, we can note that branches of the hepatic artery approximate the caliber of branches of the portal vein. This is a reflection of increased arterial flow and decreased portal blood flow to the liver. Note also the tortuosity of hepatic arteries, and also note that there are areas where we see red and not blue. That means that the portal venous channels were obliterated, and we still see persistence of arterial blood supply to those areas. This is what I call the red liver of advanced cirrhosis with marked hepatofugal blood flow. Note that the blue is markedly reduced, and the blue was injected into the portal vein, and the whole liver is red, and we see not only a marked increase in hepatic arteries, but also we see some arteries in the surface of the liver. This is a close-up of a segment of the same liver. Observe that there are dilated arteries in the periphery. This will be the equivalent of capillary hemangiomas or spider angiomas, which represent expansion of collateral vessels in the region of the capsule of the liver. The marked increase in the hepatic vascularity is secondary to a decrease in portal flow and increase in the regenerated phenomena that occurs from liver cell necrosis. The nutritive arteries of the liver enlarge, while the portal vein is not a nutritive vessel for the regenerated nodules. So the two mechanisms for increased arterial flow is a decrease in portal flow and the need for more blood for the regeneration of the liver parenchyma, which is supplied by the hepatic arteries. This is a table that represents the hepatic collaterals, which are divided into intrahepatic and extrahepatic collaterals. We are going to show you very shortly the documentation of the collateral pathways to the liver, but this is only in reference to the arteries. The collaterals that we're going to demonstrate are the connecting vessels to the portal venous tree. Portal collateral circulation is observed in a patient with portal hypertension. We see retrograde flow in some tributaries of the portal vein, particularly the coronary vein, and we see the opening of channels that connect the portal system with the systemic circulation. The classic division of collaterals has been the ventral collaterals of the plexus of Sappi and the retroperitoneal collaterals of the plexus of Retzius. Note in this diagram the enlargement of tributaries and the presence of collaterals. We can see them around the duodenum, in the stomach, esophagus, in the hilus of the spleen, around the pancreas, and around the kidney, as well as in the wall of the bowel. So hemorrhoids, small and large bowel varices, gastric and esophageal varices are a common phenomena as a result of portal hypertension. Note also a vessel that connects the left branch of the portal vein with the umbilicus, and this is the umbilical and periumbilical venous system of plexus of Sappi that can be often demonstrated on physical examination by the so-called caput medusa in the anterior abdominal wall around the umbilicus. This is a close-up of a cast which shows that in the surface of the portal vein, which is depicted in yellow, we see a network of arteries. The arteries are also surrounding biliary radicals. And this is to show that the hepatic arteries provide the vasa vasorum to the portal vein and its branches, and also provides blood supply to the biliary tract. This is a close-up of the hilus of the liver, which was affected by cirrhosis, and blue plastic was injected in the portal vein, red in the hepatic artery. And we note that close to the hilus, we see purple vessels. Now, why are the vessels purple? Because of the mixing of the blue in the portal vein with the red in the hepatic arteries. Now, why does that happen? It occurs because the hepatic artery provides the vasa vasorum of the portal vein. And it is possible to demonstrate the rapid filling of the portal vein from a hepatic arteriogram before contrast has reached the periphery of the liver vascular bed. In other words, when the blood in the hepatic artery reaches the liver lobule at the level of the portal triad, blood from the artery and from the vein mix at the level of the liver lobule, and they both perfuse the sinusoids of the liver. So communication normally exists at the level of the liver lobule, but communication can exist proximal to the liver lobule because of the vasa vasorum of the portal vein, which is supplied by the hepatic artery. And we shall show you later the mechanism of arteriovenous communications that can be demonstrated when doing hepatic arteriography. This is a common hepatic arteriogram in a patient with cirrhosis and portal hypertension. Note that the hepatic artery is enlarged, not only close to the hilus, but within the liver. And note in the bottom images that early in the arterial phase, we see opacification of the portal vein. How can the portal vein become opacified? Either centrally by the expansion of the vasa vasorum, and peripherally by the communication between hepatic arterioles and portal venules. This patient had severe obstruction of the transhepatic portal flow through the liver, and there was also a very large collateral pathway towards the portal vein from the expanded vasa vasorum of the hepatic artery. So this is arteriovenous communication that occurs in the central portion of the liver. Communication between the hepatic artery and the portal vein can be seen in obstruction of the hepatic vein, so-called Budd-Chiari syndrome, in cirrhosis of the liver, and intrahepatic portal fistula that can be congenital, traumatic, arteriosclerotic, or idiopathic. And finally, in tumors of the liver, particularly hepatomas and some metastases, such as in leiomyosarcoma, hemangiosarcoma, and hemangioendotheliomas of the liver, there can be extensive communication between the hepatic artery and the portal vein. This may lead to some degree of hyperkinetic mechanism for portal hypertension. This is just to show a tracing of the wedged hepatic studies where one can record a wedge pressure. In this case was 40 millimeters of mercury, and a free hepatic vein pressure of 2 millimeters of mercury. So this patient had severe portal hypertension with a gradient of 38 millimeters of mercury. Normally the gradient should be less than 5 millimeters of mercury. So we always do manometry when wedge hepatic vein studies are performed before the injection of contrast. In this patient, a wedged hepatic venogram following manometry revealed filling defects in the segment that was infiltrated with contrast, and the portal vein readily fills from the wedged hepatic venogram. We can suspect that this patient had a hepatofugal portal blood flow, and in such a case, the portal vein has become an outflow tract to the liver, and the only inflow tract of blood to the liver is via the hepatic arteries. Patients that have advanced cirrhosis and chronic vascular adjustments usually respond better to portal systemic flow diversion than those that maintain portal flow to the liver. That is why the classic end-to-side and side-to-side portocaval shunts have been replaced with the distal splenorenal shunts. One can arbitrarily classify the severity of cirrhosis with portal hypertension by wedge venous studies. We go from a grade 1 to a grade 4 from top to bottom, and grade 1 means minimal elevations of wedge pressure with minimal distortion. The grade 4 shows intravenous anastomosis and that the portal vein has become an outflow tract to the liver. So these morphological changes correlate with the severity of portal hypertension. This patient had a 20 millimeter gradient between the sinusoidal wedge pressure and the free hepatic vein pressure. There was also free flow of contrast into branches of the portal vein. So this is a case of a category 4, a severe degree of portal hypertension, where the portal vein has become an outflow tract to the liver, and this is a reflection of hepatofugal portal blood flow. In this study of the portal system, we note that the splenic vein and the mesenteric vein opacify, but we do not see filling of the portal vein. Do we have anatomical or functional obstruction of the portal vein? Another example, hepatofugal blood flow. Note that we fill the splenic vein and the coronary vein and gastroesophageal varices, and there is a poor filling of a small portal vein. This means that the portal vein has become an outflow tract to the liver, and these are individuals that generally respond best to the classic portocaval shunt operation or to the TIPS, because the liver has already adapted to a decreased portal blood flow, and there has been usually enough arterial blood flow to the liver to maintain the morphologic and functional integrity of the remainder of the liver parenchyma, and particularly the regenerated parts of the liver. In this portographic examination, we see both the anterior and the posterior collaterals. Is well demonstrated. Note the reflux into the inferior mesenteric vein. That explains the high incidence of hemorrhoids when this happens. Note also the large coronary vein that fills the gastric varices. And note that we see a filling of the proximal part of the umbilical vein that connects with the left branch of the portal vein. This is another collateral pathway between the portal vein and the hepatic veins, and this is through the ductus venosus. The ductus venosus connects the left branch of the portal vein with the inferior vena cava and generally obliterates, and it is analogous to the ductus arteriosus that becomes fibrotic usually after the age of 3 months. One can get a communication between the portal vein and the inferior vena cava through this vessel. In this cadaver study, we see filling of the portal vein and of the inferior vena cava, and this occurred through a ductus venosus, which was patent. This same patient to the right and above, you can see the filling of the left renal vein and inferior vena cava through very large collaterals. Collaterals may connect the splenic vein to the left renal vein. This is another mechanism of portosystemic communications, and actually the surgeon tends to use the distal splenorenal shunt to artificially connect the splenic vein to the left renal vein, but some individuals have spontaneously developed portosystemic anastomosis between the splenic vein and the left renal vein, as in this case. This first case of markedly enlarged umbilical vein shows the venous return from a splenic artery injection. Note the large size of the spleen, and note the paucity of branches of the portal vein, because blood going into the liver is readily diverted into a very large umbilical vein. These are individuals who often suffer of hepatoencephalopathy because of very large portal systemic communications. So it is not only the lack of detoxification of splenic blood entering the liver because of obstruction of the intrahepatic branches of the portal vein, and that obstruction is both anatomical and hemodynamical, but also the easy flow diversion that has occurred to systemic veins that connect at the level of the umbilicus with cephalic and caudal branches that eventually end up in the systemic circulation. This is called also the Cruvelier-Baumgarten syndrome, which can be congenital or can be acquired. This is another example of the enlarged plexus of Sappi, that is enlarged umbilical and paraumbilical veins. Note the large vein that goes from the hilus of the liver to the region of the umbilicus. This patient had a large caput medusa, and like the previous case, hepatoencephalopathy was the dominant finding. This is a cadaver study of a patient who died with portal hypertension secondary to diffuse alcoholic liver disease. Note the small size of the liver, which contrasts with the enlarged spleen. Note the caliber of the portal vein and the winter tree pattern due to obliteration of intrahepatic branches of the portal vein. Note that the spleen is plethoric, and also we see enlargement of the coronary vein, which supplies blood to the gastric varices. We were fortunate in the early 70s to perform the first transhepatic catheterizations of the portal vein. My friend Anders Lunderquist, then at Lund, was collaborating with us, and he also did the first in vivo transhepatic catheterizations of the portal vein. And we call that technique transhepatic portography. It is a technique where a trocar is advanced into the liver, and as soon as it enters a branch of the portal vein, a guide wire followed by a catheter is introduced, and then direct manometry and morphological studies of the portal vein are performed. And this is a technique that we used extensively to obliterate the gastroesophageal varices. This transhepatic portogram shows a large tributary, which is a coronary vein, and filling of gastric and esophageal varices. Not only we can map the collateral pathways, but we also can detect active bleeding varices, and finally use this technique to obliterate these tributaries and collaterals to the portal system. In this patient with transhepatic portography, we note the massively enlarged coronary vein with very dilated gastric varices, as well as veins in the distal esophagus. This was my first case of transhepatic obliteration of the coronary vein. Note in the radiograph above the filling of the coronary vein, and below the adequate obstruction of flow into the coronary vein after the use of gel foam and Sotradecol. And these were the two agents that were utilized for these type of transhepatic obliteration of gastroesophageal varices. Actively bleeding varices can be demonstrated as indicated in this patient. Note that in the last image, we see a blush at the level of the esophagus and stomach, and this was the bleeding site of esophageal varices. There are two ways of obliterating these varices. The usual way is by endoscopy, and the other way is via the selective catheterization of the portal vein. Compression of the varices can occur if we use the Senstack and Blakemore tube or similar devices where a balloon is distended in the fundus of the stomach and distal esophagus, and in that way the varices are compressed. This, in my experience, is not as effective as the direct obliteration of varices. In this patient, we injected gel foam and sotradecol into the coronary vein, and note the marked enlargement of the gastric and esophageal varices, and there was some extravasation of the contrast. Hematoma was visualized around the esophagogastric junction. In this patient with successful obliteration of the coronary vein, the pressure in the portal system rose from 28 to 44 millimeters of mercury. And this is not uncommon, and often as a result of an aggravation in the portal hypertension, portosystemic collaterals that do not bleed open. And this is our hopes in some individuals, where we can see flow diversion into the left renal vein and from there to the inferior vena cava. In this patient, we first obliterated the coronary vein. However, the patient continued bleeding. So the first two images show the obliteration of the coronary vein. However, note that there are veins connecting the spleen with the fundus of the stomach. The short gastric veins were then selectively catheterized and embolized. And this is one of the very beautiful cases that my dear friend Raul Pereiras, who died a few years ago at a very young age, performed. So this is to show that occasionally it is not possible to stop bleeding by just obliterating the coronary vein. One has to be thorough and advance the catheter to the hilus of the spleen and then try to enter the short gastric veins. And in this way, we can interrupt the flow to the esophagogastric region. This next patient also shows the obliteration of the coronary vein and of the short gastric veins. Sometimes hematoma produce narrowing of veins, but this is a temporary phenomena. We must inject the gel foam or sotradecol, or use some coils to permanently interrupt the flow in these very important source of gastroesophageal varices. In these three images of another case, we can see the completion of the obliteration of gastroesophageal veins following the selective injection of gel foam and sotradecol. In these four images, we note a very large coronary vein that was obliterated. However, the patient developed a hematoma, and that is the extravasated contrast that we see in the bottom left image. Following the successful obliteration of all the gastroesophageal veins, you can see at the bottom right a perfectly normal splenic and portal vein. Flow diversion occurred in this patient towards the left renal vein. Sometimes we have to do the procedure in 2 consecutive days. In this patient, the first two images show the presence of gastroesophageal varices in the top and bottom image. In this patient, the following day, another attempt was made to obliterate other vessels. And the final result is the successful obliteration of gastroesophageal varices and the large portosystemic communication between the left renal vein and the splenic vein. Obliteration of gastroesophageal varices sometimes leads to opening of spontaneous splenorenal shunts, as indicated in this case. And note in the top left the presence of collaterals that are located in the fundus of the stomach. The top right shows the successful obliteration of these tributaries to the portal system. The bottom images reveal large collaterals that connect the splenic vein with the left renal vein. So successfully we have taken advantage of pre-existing collaterals to induce a splenorenal shunt. So in theory, this patient does not need any surgery. This is a cadaver study where the inferior vena cava was injected after ligating its junction with the right atrium and below the renal veins. Note the retrograde filling of the renal veins, splenic vein, coronary vein, and of the spleen. So the splenic vein in this case was anastomosed to the side of the left renal vein. So this is a splenorenal shunt, which is one way of treating gastroesophageal varices from portal hypertension. Note that in this particular case, the surgeon did not ligate the coronary vein, so it is possible to continue with variceal bleeding despite the successful spinorenal shunt. The next 6 slides correspond to a patient who had several connections between the portal vein, so the splenic vein, and the gastroesophageal region. Note in the first 4 images the successful obliteration of the coronary vein after selective catheterization of this vessel. The bottom right shows no flow going from the portal system into the fundus of the stomach. The next 2 images show the successful obliteration of one of the short gastric veins, as demonstrated with the arrow on the image to your right. The third set of images reveal several veins connecting the splenic vein with the fundus of the stomach. I arbitrarily labeled them X, Y, and Z. And note that the bottom slide shows that some of these veins have been already successfully obliterated. The last 4 images of the short gastric veins reveal the successful obliteration as demonstrated on the bottom right image. Finally, despite the successful obliteration of veins X, Y, and Z, we could see that from the left portal vein, a large collateral was connecting the portal system with the esophagogastric region. Note that upon selectively catheterizing the left portal vein and obliterating it, we have stopped the flow to the esophagogastric region. This patient died as a result of liver failure, and at postmortem examination, we were able to demonstrate the persistent obliteration of veins X, Y, and Z that supplied the fundus of the stomach and the distal esophagus. The specimen shows a cast of these vessels. The next 5 images are of a patient who was successfully embolized in the month of January, as seen in this image. Note that the coronary vein is occluded. In May, this patient was restudied because of repeated bleeding varices, and one can see a vein going from the splenic vein towards the fundus of the stomach. The last 3 images correspond to a superselective catheterization of the short gastric veins with eventual obliteration of the veins that supplied most of the fundus of the stomach. Still, we see persistent collaterals at the level of the distal esophagus. The technique of transjugular intrahepatic portosystemic shunt is the most popular radiological interventional procedure performed in patients with portal hypertension. It can control variceal bleeding in patients with failed sclerotherapy. It appears to be useful in the long-term control of variceal bleeding, and particularly is useful in patients that have advanced liver disease and are candidates for liver transplants. It is not possible in this CD-ROM to describe the steps of the technique. Suffice is to say that a catheter is introduced into the hepatic vein. The connection of the hepatic vein with the portal vein is obtained, and the stent that is finally deployed is placed at the site of the track. The track can be dilated with a balloon, or the balloon dilatation can be preceded with a stiff catheter for dilation purposes. Sonography has been utilized following the creation of tips, both for the detection of significant procedure-related complications and in the surveillance required to assure a long-term assisted patency of the shunt. This final image of a TIPS shows the connection between the portal vein and the hepatic vein. This patient had a TIPS, and we can see in the axial image the rounded density that represents the stent. In the sagittal reconstruction we note the presence of the stent that connects a hepatic vein with the portal vein. In patients who have a predominant hepatopedal circulation, which means that the liver is receiving considerable blood from the bowel, the technique of transjugular intrahepatic portosystemic communication and the classic portocable shunt will deprive the liver of portal flow, and these individuals may have a relief of the pressures in the portal system, but are often condemned to hepatoencephalopathy because the liver suffers from the ischemia created by the stent or by the portocable shunt procedure. Therefore, the procedure of choice is the so-called distal splenorenal shunt, popularized by my friends Warren and Seppa, who were professors of surgery of University of Miami. In such a procedure, the splenic vein is disconnected from the portal vein, and it is connected to the left renal vein, and the coronary vein is ligated. So blood goes from the fundus of the stomach to the splenic venous system, and from there to the left renal vein. In this technique, the splenic flow is preserved, and therefore the complications of hepatoencephalopathy are not as great as with the other surgical procedures. One elegant way of showing the patency of a splenorenal shunt is to obtain coronal MRI studies, and in this case one can see that the splenic vein is connected to the left renal vein, and these two vessels are patent. Portal vein obstruction can be divided into intrahepatic and prehepatic. Typically, in patients who have schistosomiasis, one gets a pre-sinusoidal or intrahepatic portal vein obstruction. We're going to discuss now the prehepatic portal vein obstruction. Usually it's thrombosis, which can be idiopathic or secondary to tumor invasion of the portal vein, like, for example, pancreatic carcinoma. Due to hepatocellular disease, extrinsic pressures on the portal vein, intra-abdominal sepsis with phlebitis, or blood dyscrasias. In infants, omphalitis and umbilical vein catheterization procedures can become complicated with the portal vein thrombosis. Sonography, CT, MR angiography, and invasive angiography such as splenoportography or indirect portography injecting the SMA can show the portal vein thrombosis. In this case, a splenoportogram shows a large filling defect at the level of the portal vein, and note as an incidental finding the opacification of an umbilical vein. The next 5 images is of a patient who had idiopathic portal vein thrombosis. The first image is a color addition angiogram where the superior mesenteric artery appears in red and the portal vein in blue, and we could not see adequately branches of the portal vein within the liver and a single portal vein. So the diagnosis of portal vein thrombosis was suspected. Wedged hepatic venography showed a normal parenchyma and normal pressures. However, it was easy to fill intrahepatic branches of the portal vein, which appeared radiographically normal. This is another indirect sign when the pressures are normal that we are dealing with a pre-sinusoidal form of portal hypertension. A celiac injection revealed increased size of the hepatic arteries and a uniform diffuse opacification of the liver. This is an expression of compensatory hepatic arterial hypervascularity as a result of the liver becoming deprived of blood from the portal vein. Operative portogram shows several veins in place of the portal vein. These represent antegrade periportal collaterals. They do not branch uniformly as we should expect from the portal vein. And interestingly, we could see opacification of the veins in the wall of the gallbladder. This patient had filling defects in the wall of the gallbladder that were originally suspected of being related to hyperplastic cholecystosis, when actually they represented varices of the wall of the gallbladder. A cava mesenteric shunt was performed, and following surgery, injection of the superior mesenteric artery in the venous phase shows the connection of the superior mesenteric vein to the inferior vena cava, showing patency of the shunt. This is one way of treating portal vein thrombosis. Another cause of portal hypertension is the Budd-Chiari syndrome. The causes of Budd-Chiari syndrome start with the blood dyscrasias, polycythemia vera, paroxysmal nocturnal hemoglobinuria, lupus anticoagulant or antiphospholytic syndrome, antithrombin 3 deficiency, protein C deficiency, and protein S deficiency. All these can lead to thrombosis of the hepatic veins. The neoplasias associated with Budd-Chiari are hepatocellular carcinoma, which can invade the hepatic veins. Renal carcinoma that often invades the cava and in a retrograde fashion can invade the hepatic veins, and adrenal carcinoma. Infections can also cause Budd-Chiari syndrome, particularly amoebic disease. Other causes of Budd-Chiari syndrome are following bone marrow transplantation, and the consumption of some herbal products, and particularly bush tea. Bush tea has a high content of sinecio alkaloid, and this has been described in several countries of the world. And the alkaloids that seem to obliterate the hepatic venules are the pyrrolizidine. Following chemotherapy, particularly the use of urethane, azathioprine, mercaptopurine, and thioguanine can lead to Budd-Chiari syndrome. Irradiation of the liver, and the use of some antibiotics, particularly vancomycin. And in 30% of patients with Budd-Chiari syndrome, we cannot identify a specific cause. In patients with Budd-Chiari syndrome, in contrast to the normal circulation, which is outlined on top, the bottom image shows the reversal of flow in the portal vein and the presence of gastroesophageal varices. The liver undoubtedly enlarges. Splenomegaly is not as conspicuous as in patients who have cirrhosis with portal hypertension, and ascites can also occur. We're going to now describe a very interesting patient, the wife of a physician, age 42, who after returning from a trip to a Central American country, complained of enlarged abdomen. And at the clinical examination, there was evidence of hepatomegaly. The liver function tests were not abnormal. And this woman had no history of alcoholic intake, no history of hepatitis. The 4 CT images that are shown revealed hepatomegaly and a filling defect in the right lobe of the liver, as seen in the top right image. Note splenomegaly, and note also a group of densities in the topography of the hilus of the spleen. One of the CT images is shown here, which revealed the hepatomegaly filling defects, particularly in the right lobe of the liver, splenomegaly, and a density in the hilus of the spleen. At this time, we suspected the possibility of a malignancy, such as a carcinoma of the pancreas that may have obliterated the splenic vein and had metastasized to the liver. Another possibility was of a lymphoma. Clinically, this woman had no evidence of a visceral malignancy. A phagocytic liver scan was obtained, which failed to demonstrate the focal lesions in the liver, and there was a prominence of the caudate lobe. A selective left splenic arteriogram failed to demonstrate encasement or obstruction of the splenic artery and evidence of a markedly enlarged spleen. This is the venous phase of the selective splenic artery injection. Note uniform splenomegaly. Note a density in the hilus of the spleen that represent dilated veins, that is collateral circulation. Note that we do not see the splenic vein because it was occluded, and that's the reason for the veins in the hilus of the spleen. Note that the portal vein is opacified except for the intrahepatic branches of the portal vein. So at this stage of the study, we diagnose the presence of splenic vein thrombosis. A superior mesenteric artery injection revealed the common hepatic artery, which opacified in a retrograde fashion through the pancreatico-duodenal arcades, particularly the gastroduodenal artery, and the antegrade filling of the intrahepatic arterial branches failed to demonstrate any degree of hypervascularity and no evidence of a tumor. The venous phase of the SMA injection shows patency of a normal appearing portal vein, but note that there are no branches that we can see supplying the left lobe, and very few branches seen in the right lobe of the liver. At this stage, a diagnosis of a hepatoma could not be made because there was no arterial hypervascularity, and we could not explain the splenic vein obstruction. The diagnosis of a pancreatic lesion could have explained the obstruction of the splenic vein, but would not explain why we don't see branches of the portal vein as normally predicted. So at this stage of the game, we could only diagnose a distal type of portal hypertension due to splenic vein obstruction, but the etiology was not well established. Selective hepatic venography revealed the pathognomonic signs of veno-occlusive disease of the hepatic veins, that is the Budd-Chiari syndrome. Note obstruction of hepatic veins and a very rich intrahepatic network of veins. This same finding was seen in both lobes of the liver. The patient was explored because they still suspected metastatic disease to the liver to explain the filling defects that was observed in the liver CT examination. And at the surgery, multiple yellowish nodules were observed and biopsied. Still, the diagnosis initially was of metastatic disease. Histological sections revealed multiple areas of infarction of the liver, the so-called Zand infarcts. And you can see in this microscopic examination obliteration of a central vein with the hemorrhage around the vein. The phlebosclerosis was observed in many intrahepatic venules, and there was also evidence of considerable collateral venous circulation. This is another example of a Budd-Chiari syndrome. Note that the catheterization of the hepatic vein shows numerous venules that are opacified from different areas of the liver, and the loss of the normal appearance of the intrahepatic veins. This image again is pathognomonic of the Budd-Chiari syndrome. This cast corrosion preparation explains the venographic findings. That is that we have potential intravenous anastomosis among the hepatic veins as seen in this cast. Particularly in Asia, veins that drain the liver may contain diaphragms, and even in the inferior vena cava and at the junction of the hepatic vein with inferior vena cava, incomplete and complete septa have been described. They have also been considered as webs. And this is a sonographic examination which shows a web at the junction of hepatic veins with the inferior vena cava. Another image of the same patient shows the membrane interposed between the inferior vena cava and the junction of hepatic veins. In patient with Budd-Chiari syndrome, in addition to hepatomegaly and slight to moderate splenomegaly, we may see ascites. And this CT examination shows these three findings: hepatomegaly, splenomegaly, and ascites. A patchy geographical enhancement of the liver has been described with Budd-Chiari syndrome, as demonstrated in this CT scan of the liver. MRI angiography can reveal the patency of the hepatic veins and also show membranes at the level of the hepatic vein when this is the cause of the Budd-Chiari syndrome, as seen in this coronal image of the liver. A high signal from a thrombus in the hepatic vein is demonstrated in this coronal image of the liver. Note the white density that represents the thrombosed hepatic vein. These are two examples of obstruction of the inferior vena cava due to membranes or diaphragms, another rare cause of body carrier syndrome. Following thrombotic occlusion of the inferior vena cava, one may dissolve the thrombus with fibrinolytics, and subsequently, if there is an area of narrowing of the inferior vena cava, it can be dilated. A stent can be placed, and these are ways that radiologists can help in the treatment of thrombotic occlusion of a hepatic vein with secondary thrombosis of the hepatic vein causing the Budd-Chiari syndrome. Another cause of portal hypertension is increased flow without increased resistance, and that is whenever we have a arteriovenous communication. It can be between the hepatic artery and the portal vein, or between the splenic artery and the splenic vein. This is a patient of a splenic arteriovenous fistula, where sonographic examination in the axial plane revealed the marked enlargement of the portal vein and large gastroesophageal varices. Celiac angiographic examination revealed a relatively small hepatic artery, in contrast with a massively dilated splenic artery and very large vessels in the left upper quadrant. In the venous phase of this celiac trunk injection, we can see a dilated splenic and portal veins and a large fistula that was present in the spleen. Note also opacification of gastroesophageal varices. So this is a classic example of a hyperkinetic type of portal hypertension secondary to an arteriovenous fistula. It must be remembered that there is some degree of hyperkinesia when the spleen is enlarged in patients who have cirrhosis of the liver. So increased flow to the spleen can result in increased flow to the portal vein, contributing to the portal hypertension. We're going to discuss now extrahepatic manifestations of liver disease, specifically cirrhosis with portal hypertension. The first one is gynecomastia, and this is a male with gynecomastia. He was not taking digitalis, he was not taking hormones, and this is the gynecomastia that is seen from the lack of detoxification of estrogens by a sick liver. The patient had no products injected into the breast, and this was true gynecomastia, not lipomastia, which is more common and seen in obese individuals. This is an individual who was not obese, and the enlarged breasts were secondary to liver disease. In males, we also have to consider a tumor that may be producing estrogen, particularly adrenal adenomas or adrenal carcinomas. A high position of the diaphragm is often the result of hepatosplenomegaly, ascites, or a combination of both. And in this patient, you note that the lungs are free of infiltrates, but the high diaphragm and the overall whiteness of the abdomen were the result of hepatosplenomegaly and ascites in a patient who had liver cirrhosis. Tension ascites may be followed by pleural effusion. In this case, the right pleural effusion increased considerably. This patient had ascites, and at the time of tapping, a small amount of air was injected in the acidic fluid, and upright views of the chest a few hours later revealed an air fluid level in the chest, indicative that both the fluid and the air traversed the right dome of the diaphragm. This occurs when there are congenital defects in the musculature of the diaphragm, and therefore the two cavities, the peritoneal cavity and the pleural cavity, can communicate. This is the same mechanism that has been described in patients who have a Meigs syndrome of fibromas of the ovary with ascites with pleural effusion, and the pleural effusion is a result not of implants of masses or tumors in the pleural cavity, but actually to the fluid in the belly that traverses the diaphragm and is lodged in the pleural cavity. Cardiomegaly as a manifestation of alcoholic cardiomyopathy can be observed in patients with cirrhosis. And this is an example of an enlarged heart due to alcoholic toxicity. Clinically, these patients often have cloven P waves on an ECG examination and signs of decreased cardiac contractility, which is not related to valvular or coronary artery disease. This 37-year-old woman had microcardia, and at the postmortem examination, there was a brown atrophy of the heart. Brown atrophy is a degenerative process that may lead to microcardia, so that in this case it was due to end-stage liver disease. Another observation in the chest is an enlarged azygos arch and the presence of paravertebral densities, as seen in this patient. This individual had large periesophageal varices and increased azygos blood flow explain the prominent azygos arch. This is another example of mediastinal densities to the left of the midline, outlined by the arrows, which on the right coronal tomogram were lobulated and represented the periesophageal veins. So this is a radiographic manifestation of expanded portosystemic collaterals. A bulge of the diaphragm may be the result of a mass in the surface of the liver. In this case, note that there is elevation of the medial portion of the right hemidiaphragm, no signs of subpulmonic effusion. The costodiaphragmatic angle is cleared. Selective common hepatic arteriogram showed neovascularity at the level of this area, and in the lateral view to your right, you can see the neovascularity supplying a hepatoma of the liver. Hepatomas can be primary or secondary tumors of the liver. When located at the periphery of the liver, they can produce a focal bulging of the diaphragm. Cyanosis has been described in some patients who have portal hypertension. What is the mechanism? In these two images, which is a frontal chest rentgenogram and a close-up of the right lung, we see prominent vascular markings and discrete nodules throughout both lungs. A pulmonary angiogram showed some lack of tapering of the pulmonary arteries. That explains the prominent markings, and little densities appeared in the periphery of the lung. And they actually represent the micro and some macro arteriovenous fistulae between the pulmonary artery and the pulmonary veins. The same mechanism that dilates capillaries, producing the telangiectasias of the skin, particularly around the nose and cheeks. One can see telangiectasias all over the body, and in some viscera, communication between arteries and veins can occur in certain forms of chronic active liver disease. So this is one of the mechanisms of cyanosis without murmurs in patients who have liver disease. The differential diagnosis would include microarteriovenous fistula or macroarteriovenous fistula are seen in the Rendu-Weber-Osler syndrome. The next three images correspond to another case who had cyanosis and no murmurs, and the cause was cirrhosis. The plain radiograph did not reveal the prominent vasculature seen in the previous case. However, when an angiogram was done, injection of the pulmonary artery revealed prominent vessels bilaterally and little densities that were visualized in the periphery of the lungs. In the venous phase, we note distinctly large vessels that are observed at the level of the AV communication. Some of these vessels may represent dilated subpleural arteries and veins, and the connection between the arteries and veins can be seen at the level of the lung or even at the level of the pleura. So this is another manifestation of AV communications causing cyanosis in a patient who had liver disease. Second mechanism of cyanosis has been the connection between the systemic veins and the pulmonary veins, as illustrated in this case. From the gastroesophageal region, one can see veins that communicated with intrapulmonary veins, and therefore that will be the mechanism of a right to left shunt from systemic to pulmonary veins. A barium swallow can reveal the presence of esophageal varices. A well-done barium study with a thick paste and prone and supine-oblique views with the patient doing a Valsalva will best delineate the mucosal changes that represent dilated esophageal vein, that is esophageal varices. We can see asymmetry of the folds as the first manifestation, and later on we're going to see the rounded filling defects. These two images of a barium-filled esophagus shows in the mucosal phase, which is the right image, the filling defect typical of gastroesophageal varices. And this patient had schistosomiasis as the cause of portal hypertension. When the esophagus is distended, we may not see the varices. As demonstrated in these three images, the first two show the barium-filled esophagus. The third image is the one that reveals the presence of mucosal changes that corresponded to varices. Remember that sometimes we may see downhill varices from obstruction of the cava. In patients who have portal hypertension due to liver disease, the varices typically spare the upper third of the esophagus, and we only see them in the lower two-thirds. This specimen shows the esophagus open, and the blue-green tubular densities represent the distended veins. In this case, they were totally obstructed, and this is a patient who died following embolization of the coronary vein and of short gastric veins. This is the typical location of the dilated submucosal varices. The last esophageal abnormality may be a tear of the esophagus, and this is a case where the esophagus is actually ruptured following the insertion of a Sengstaken Blakemore tube. Balloon distension of the fundus of the stomach and of the distal esophagus is used as a technique for compressing bleeding varices. And this is another modality that is employed but has its complication as well as its failures. In this case, this was a failure. Gastric abnormalities are demonstrated in the next two cases. In this first one can see a large filling defect at the esophagogastric junction. Differential diagnosis would have to include a mucosal tumor, such as a cancer. This patient had only gastric varices. This patient had filling defects in the fundus of the stomach. Differential diagnosis, enlarged gastric folds, lymphoma, carcinoma. These folds were prominent because of large gastric varices. Another case where there were no esophageal varices and only gastric varices were present. This patient with alcoholic liver disease and portal hypertension had mucosal changes in the second part of the duodenum and throughout the jejunum. The second part of the duodenum shows spasticity and discrete mucosal changes. One might consider duodenitis, one might consider giardiasis, or the duodenal effects of pancreatic disease. However, when we see also associated speculation and mild dilation of jejunal loops, one has to suspect liver disease. Sometimes a combination of dilated veins and thickened folds from edema due to hypoproteinemia are the causes of these morphological changes, as seen in this case. These are two images of a transhepatic portogram which shows some tributaries to the portal vein in the topography of the second part of the duodenum and head of the pancreas. This patient had duodenal varices that were characterized by the mucosal changes described in the previous case. Other small bowel changes include the separation of bowel loops when a patient has ascites and a disorder motor function pattern demonstrated in this image. Note the segmentation of the barium column, and these are findings that are often seen with conditions such as sprue. Quite often patients that are poorly nourished have a small bowel pattern that looks like this. So again, when we see such an abnormality, we must inquire in the history of the patient and rule out the possibility of diffuse liver disease. Colonic changes are characterized by either displacement of the colon, as demonstrated in this image. And note that the transverse colon and the hepatic flexure are displaced caudally, and occasionally we may see indentation of the superior row of colonic haustra when there are large nodules seen in the surface of the liver. Metastatic disease, post-necrotic cirrhosis, and syphilis are among the entities that indent the superior row of colonic haustra and are associated often with the focal or diffuse displacement of the large bowel. Diffuse mucosal changes, as seen in this barium enema, presents several differential diagnoses. This patient happened to be asymptomatic in reference to the large bowel. Therefore, we have to assume that we're dealing with benign edema of the bowel wall. We can see that in colonic urticaria, but primarily we see it in conditions that have a hypoproteinemia. When the total amount of protein is under 4 grams and the total amount of albumin is less than 2 grams, edema of the bowel may result. And this is what happened in this case. There is transverse ridging due to edema of the folds, and the differential diagnosis would have to include a type of colitis, be that inflammatory or ischemic colitis. Ischemic colitis, in order to involve the entire colon, must be of the hypovolemic type, the so-called non-occlusive ischemia, where changes can occur in the territory of both the superior mesenteric and the inferior mesenteric arteries. Opacification of the gallbladder in this patient revealed fine filling defects in the wall of the gallbladder. The differential diagnosis would have to include hyperplastic cholecystosis, any type of polyposis of the gallbladder, less likely stones, and varices of the gallbladder. This patient had portal hypertension due to liver cirrhosis, so obviously the first diagnosis to entertain is of gallbladder varices. A sonogram in this patient revealed some thickening of the wall of the gallbladder, but particularly these rounded, lucent areas. This is pathognomonic of varices of the gallbladder. Thickening of the wall of the gallbladder is a nonspecific finding that can be seen with edema of the gallbladder, with ascites, with cholecystitis, carcinoma, lymphoma, Kaposi sarcoma, etc. But this patient had no symptoms referable to the gallbladder, and the filling defects with a positive Doppler study made these lesions pathognomonic for gallbladder varices. This is a cast corrosion preparation of the liver, where yellow plastic was injected in the portal vein and green in the biliary tract. Note yellow vessels in the surface of the gallbladder. A close-up of the gallbladder region shows the yellow vessels that represent the veins of the wall of the gallbladder. The gallbladder drains into the portal system, and there are no valves separating the intrahepatic portal veins from the veins of the wall of the gallbladder. This is a mechanism of a spread of gallbladder disease to the liver. Gallbladder disease, be that inflammatory or neoplastic, can spread via contiguity, via the lymphatics, through the biliary radicals, and hematogenous spread from the gallbladder veins into the portal vein. So remember that the presence of filling defects in the wall of the gallbladder, one has to consider gallbladder varices. The pathognomonic signs of gallbladder varices are the filling defects seen on sonography with a positive Doppler test indicative that these are vessels that are distended. This is a patient who had small filling defects along the walls of the proximal common hepatic duct, and these were not due to mucosal changes, they were due to varices. So paraduodenal, juxtapancreatic, and pericholecystic and perihepatic veins can dilate as a result of portal hypertension. So that should be in the differential diagnosis of small mural filling defects along the biliary tree. Sonography of the liver may reveal not only the presence of portal hypertension, but the cause of portal hypertension. This is a sagittal sonogram which shows a normal anatomical relationship between the hepatic veins and the inferior vena cava. This patient had invasion of the hepatic veins by a hepatoma. Here we can see the presence of ascites. These two cases show different echographic pattern that can be seen with fatty infiltration of the liver. These are two examples of portal vein hepatic vein communication. Note in this patient the presence of umbilical vein enlargement, and this is a manifestation of enlargement of the plexus of Sappi, which are the ventral collaterals between the portal vein and the systemic veins. In this patient, note an echogenic area within the portal vein due to thrombosis. This is a sagittal scan in the midline showing a dilated left gastric vein as well as the superior mesenteric vein. In this sagittal scan, we see dilated short gastric veins. Here we see dilated short gastric veins and the splenic vein. Note in these two images dilation of short gastric veins. Sonography is undoubtedly an inexpensive, readily available, informative test that should be used as the first one to assess a patient who may have portal hypertension. Not only can it show the evidence of portal hypertension, but also its causes. It also can define the flow of blood in channels and particularly the direction of blood flow when sonography is associated with Doppler techniques. Here we note a cross-section of the abdomen revealing hepatosplenomegaly, a dilated umbilical vein. Phagocytic liver scans will reveal the disparity in the sizes of the liver and spleen. And normally the liver is larger than the spleen. Here we can see the liver smaller than the spleen, which appears quite active. In this phagocytic liver scan, we again note the diffuse uptake of the enlarged spleen. Blood flow to the organs and the activity of the reticuloendothelial system explains the images obtained on phagocytic scan. The same findings are observed when doing MR using a paramagnetic contrast agent that will be selectively picked up by the reticuloendothelial system. Hotspots on hepatic phagocytic scans of the liver can be the result of regeneration of the liver parenchyma. Remember that histologically we showed you that in regenerated liver parenchyma on the Van Gieson techniques, we can stain and increase number of Kupffer cells, which are the number one phagocytic cells of the liver. We can also see it in patients who have caval obstruction, both the superior as well as the inferior vena cava obstruction. In the Budd-Chiari syndrome, particularly in the region of the caudate lobe, hemangiomas, hamartomas, abscesses, focal nodular hyperplasia, iatrogenic conditions such as malposition of catheters, and rarely in hepatomas, we may see increased activity, the so-called hot spot on the hepatic phagocytic scintigraphic examination. CT of the liver will show in some patients the presence of excessive fat as demonstrated here. Note that the spleen is denser than the liver and that the vascular structures that are seen in the liver represent the branches of the portal vein. Focal deposition of fat in the liver can appear as solitary or multiple low-density areas. They can be large or they can be small, as seen in these two patients. The differential diagnosis will have to include other conditions where we see rounded low-density areas, such as benign and malignant tumors, and also in individuals who have infarction of the liver. In this patient, triangular low-density areas were seen with the base of the triangle towards the surface of the liver. The differential diagnosis would have to include infarcts of the liver. These proved to represent echogenic areas from fatty deposits in the liver. Focal fatty deposits can appear disseminated throughout the liver, and in a way they can mimic a metastatic disease and even a polycystic disease. Obviously, the CT values of fat are almost pathognomonic of fat and will not be seen in other conditions. These 4 images are of a patient who had a fatty liver, cirrhosis, and portal hypertension. Note that in the first 2 images, we see the low-density liver with prominent branches of the portal vein. Note in the second picture that we see dilation in the region of the umbilical vein, and this is a manifestation of the anterior plexus of Sappi. The third and fourth images reveal the prominent veins in the periodic and retroperitoneal region, as well as in the mesentery. Also note the thickening of the wall of the gallbladder. So this patient had evidence of fatty metamorphosis and signs of portal hypertension. Contrast CT examination of this patient shows evidence of ascites, small liver, and the presence of opacified large gastroesophageal varices. This is a CT of the liver in a patient with macronodular cirrhosis. And note the irregularity in the liver contour, and the irregular densities is seen throughout the right lobe of the liver. MRI coronal section shows the portal vein branching at the hilus of the liver, and note that we also see a right hepatic vein. The size, shape, and the texture of this liver appear normal. In this coronal image, we can see the inferior vena cava and right hepatic veins draining into it. This patient had a cavernous transformation of the portal vein. Instead of observing a single portal vein, we can see what appears to be enlarged portal vein. Actually, they represent antegrade periportal collaterals that expand secondary to the thrombosed portal vein. Another clue is to note that there is an abnormal branching of the portal veins within the liver. Often this is the result of omphalitis or secondary to umbilical vein transfusions in newborns. Extra and intrahepatic shunts can be demonstrated on MR examination, as well as the result of surgical procedures, such as the distal splenorenal shunt. In this case, one can see a right branch of the portal vein that appears enlarged, and above it a hepatic vein. This patient had a communication between the portal system and the hepatic veins, as is demonstrated in the angiogram to the right. Fatty livers can be suspected on ecography, CT, as well as MRI. Note in this axial section that the density of the liver is different than the density of the spleen. Depending on the pulse sequences, we can see the fat brighter or darker than the spleen. Both structures should be almost identical if the liver was not diffusely infiltrated by fat. And remember that fatty metamorphosis can affect the liver diffusely or focally. And the focal involvement can be localized or affect multiple areas of the liver. In this coronal image, we can also observe the fatty liver. This diagram shows the normal relationship between the superior mesenteric vein and its tributaries in white, and to the left is the superior mesenteric artery and its branches. This is an MR study of a patient with portal hypertension. Note the mesenteric varices indicated by the arrows.